Good evening, everybody, and welcome to Newlife IVF's newest webinar series. We've started a monthly webinar series. This time it's called Getting to the Heart of Fertility, and we want to educate you all on what are the best ways you can help yourselves have a baby and to start a family. So welcome to the first in the series. There's going to be one each month. It's going to take place on the second Tuesday evening of each month. And we've got the schedule published on our website. Please take a look. There's some great topics coming up over the next few months and through to the end of the year. We sort of mentioned that we'd have a brief update to COVID-19 at the start of each seminar and each webinar, and really there's not much news other than that everyone is returning to work, and we think that's really great. One of the questions I'm always asked, is it safe to be at work when you're trying to have a baby? Is it safe to be at work during pregnancy? And overwhelmingly, I think that it's fine to be at work. I'm not worried about pregnant women being at work or women having fertility treatment being at work. I'm worried about them transmitting it to their family, particularly elderly members of their family. But I'm not overly, I don't think we need to be too worried about younger members in the community. We'll start the session in a moment, and we'll just a reminder again that we really love getting your questions, and there's a way of asking questions. If you look at the bottom of your screen, there's a Q&A button. If you click on that, those questions come through to us. We've had quite a few questions come through by email already. We'll answer. If you've emailed us a question, I promise you that we'll get to it. So we're going to get started now, and our first talker is Dr. Hugo Fernandes, and the topic tonight is: can I get help to fall pregnant without needing IVF? And can you get help? Absolutely, we are here to help you, and do everything we can to help with that. So the things we're going to talk about, not surprisingly, there's some big ticket items: smoking, caffeine, exercise, your weight, what to do when you're actually trying to conceive. And you might have been able to predict that they would be the things that we would be talking about, and you may well think that you know the answers already, but what you don't know is how much these things matter, and we're going to get right to the bottom of that for you tonight. So to get us started off, I'm going to invite Dr. Hugo Fernandes, one of our esteemed fertility specialists and gynecologists, and I'll be back a little bit later, and we've also got Dr. Amber Kennedy with us tonight as well. So please enjoy the evening, and don't forget to ask us lots of questions. Thank you.
Thank you for that introduction, Chris. It's good to be back doing these webinars. It's been a while for me. I've been asked to present on weight and BMI in particular, and I think it's a little bit ironic given weight and BMI, diet, etc., that doctors are probably terrible with our diets, trying to sort of get food whenever we can. And certainly I'm no Adonis, and I find it hard to eat well. So if we start with weight, I'm going to start with guys. So being underweight or overweight, whichever one is bad for fertility. BMI, normal BMI is considered to be between about 20 and 25. And whilst BMI is not a particularly good measure for weight, because there's many other factors that come into it, it's one that we all know. So 20 to 25 is considered normal. In men, there's not many studies on this area. We do know that BMI does correlate with hormones, and that obesity negatively affects the hormone levels in men. It affects the testosterone levels, and it also affects the molecules that carry around the hormones in men's bodies. What isn't really well studied is the effects of these hormones, the BMI on semen. And there is one big study. It was about 4,000 men, and BMI under 18 resulted in lower sperm, lower concentration, and lower motility, which is the how many of the sperm are actually moving and doing anything. Same way, BMI over 25, which is just getting into the obese range, also had lower semen volume, lower sperm counts, and lower motility. The issue with this is that this particular study, which is probably one of the biggest studies done, was done in Asian men, and the number of people that had a BMI over 30 was about 1%. So it's not really reflective of the entire population. Certainly, lower BMI does affect sperm. Greater BMI or higher BMI, numbers are not so strong, but we do see a fall off in our measures. Apart from weight and BMI, there's other factors to look at, and certainly my belief is that I'd rather be looking like Mr. Brad Pitt there than I won't say his name, but one of the characters from one of the Mike Myers films. In women are have many more studies in relation to weight and BMI. And what's interesting from this is just how much your childhood plays in this. Women are a little bit more sensitive to weight in so much as kids who are obese, so who have childhood obesity, even if that woman loses weight and returns to a normal BMI, a normal weight, and even if they're ovulating properly, they seem to have a decrease in fertility. And we're not quite sure why that is. Same way, if you're ovulating, which means you're having a period every month and putting out an egg every month, but you have a high BMI, you also have lower fertility. And what this points to is maybe that there's more to it than just weight. And it's possibly something to do with the way our sugars are metabolized, or in women, the way their sugars are metabolized, how they store sugar, and how that affects insulin and the other hormones that control weight. What we know is that for every 5 kilograms of excess weight, there seems to be an increase of about 5% in the amount of time that it takes to get pregnant. Being overweight is almost as bad as being underweight. So in overweight patients, they tend to have ovulatory dysfunction. So that means that rather than ovulating every month, they have a spacing in their ovulation. Sometimes that's weeks, sometimes that's months. I have patients that ovulate every 2 to 3 months. The most common presentation of this is polycystic ovarian syndrome. But a 10 kilogram weight loss typically will be beneficial. And we get 90% of women losing 10 kilos, 90% will start to ovulate, and about half of these will actually go on to be able to get pregnant. Underweight patients are a small group at the other extreme. They have a suppression of ovulation. The loss of weight or the low weight puts stress on their brain, and the hormones that are secreted to push out eggs don't get secreted in the correct way. This is manifested often in teenage girls in their sort of late teens, early 20s, who do a lot of exercise, who are very sporty, who really want to maintain their weight because of peer pressure. And those girls that really put stress on their weight and on their bodies will often stop ovulating and may have periods where they have no periods for a while. That actually manifests later on with fertility issues by the fact that they can't put out eggs and require our support. So these patients, even if they put on weight, so often it's only 5 kilograms that is needed, but often if you put on weight, they still can't ovulate and they need medical support. So being overweight, being underweight are both bad. So you want to be in the sort of middle sweet spot. If we then move on from that into later on, other than trying to get pregnant, there are other complications. So later on, there is, and say you need to move on to some fertility treatment, being overweight impacts on your follicle development. It impacts on the amount of eggs we can get, the quality of the eggs, how many of those fertilize, and also a higher miscarriage rate. And further to that, there's issues to do with pregnancy. And pretty much universally, everything is worse with the higher weight in pregnancy. So what's recommended? Well, there's a sweet spot. Obviously, the BMI is 20 to 25. That's considered what normal BMI is. And you should really try to stay in between those ranges. Weight loss or gain can be difficult, but even small changes, 5 to 10 kilos, either way can have really big impacts. So some of the lifestyle interventions are obviously exercise. Should be of a moderate activity, and even walking for sort of 30 minutes most days will help your fertility. Dietary, where you can see dietitians for that, and modify not only what you're eating, not quantities, but what you're eating so that it's healthier. 500 to 1,000 calorie change can result in half a kilo of weight loss a week. 1,000 to 2,000 calorie change can result in 10% weight loss at 6 months. So these are things that are possibly, achievable with the correct supports. What you're eating is also important. You want low GI, and you want things that are not so processed, and I'll go into that in a second. If these things are ineffective, then we obviously have things like medical treatment and surgical treatments. So let's move on to diet. So in healthy couples, there is no strong evidence that different diets, that being low-fat, vegetarian, high vitamin, antioxidants, etc., improve fertility. But this is in healthy couples, and healthy couples have very good BMIs within the correct range. They normally have good weights. They're normally doing exercise, and they're normally eating well anyway. So this is for your nice healthy couple. Really changing your diet and doing one thing or another, antioxidants, etc., that's not going to spontaneously make you pregnant. So this advice is for people who aren't within that group. And there are two main diets that people have mentioned. So one's called this fertility diet. So there is no fertility diet. This particular diet came from a study of about 18,000 women, observational. So it means that they were sort of looking backwards at what they were doing, and these women had to recall what their diets were. And they just looked at these women. They were sort of married, and they were looking at those that had difficulty getting pregnant and those that got pregnant quite easily. And when they compared these populations, this is what they found. So there was a high monounsaturated to trans fat ratio. The women tended to favour fish over meat. There was more proteins from vegetables rather than animals. Low GI, high fat dairy foods, and they seem to be on iron or other multivitamin supplements. So this is what the fertility diet is, but this is people looking backwards on what they were eating at the time. And if you sort of look at this, you sort of go, well, this is actually quite a normal diet. This is just what we consider a normal, healthy diet. The Mediterranean diet is another one that's often mentioned, and many people are familiar with this, but this is just one that's high in fruits, vegetables, legumes, and fish, and lower in protein that comes from non-fish meat, so any other animal, really. If we look at fish and red meat and try to compare these two, there's not a huge amount of studies just looking at one or the other. And that's because normally these are considered as part of a normal diet. So it's fish and meat within a normal diet. So it's a bit hard to extrapolate one over the other. But generally, the studies do show that you should try to keep fish up the top and meat at the bottom of your shopping list. Less meat seems to be better. Less meat than vegetables, less meat than fish. And so overall, less meat, I suppose, is the takeaway from that. Fish is, universally proclaimed for many benefits, one of which is fertility, and in particular, oily fish. So those contain omega-3, such as salmon. However, we do need to be careful because of the mercury levels in some fish groups, and these can be quite toxic if used regularly. So what do we recommend? Well, if you do any search online, you'll find many of these sort of charts in different colours, in different variations. But essentially, these all come down to these. So what helps fertility? Well, a diet rich in vegetables and legumes, low GI, non-mercury containing fish 2 to 3 times a week, maybe some meat on the other days of the week, but you don't have to have a protein every day. And you want to try and avoid trans fats, so things like margarines, processed food, snacks, anything from a takeaway shop. Daily consumption of red meat is probably not good, and regular fast food is also not good. So I'm going to pass on now to Chris, who's going to talk about exercise. So how can we help after you've put on that weight? Thanks, Chris.
Yes, thank you, Hugo, for that. I'm sure we'll get lots of questions towards the end about that topic. So moving right along, the effects of exercise. So a little bit similar to what Hugo was saying, that extremes of weight are both are not, neither of those are particularly beneficial. It seems that extremes in exercise are probably not beneficial either. So if you sort of think about what the effect might be on men who exercise too little, well, we know their cardiac output's not as good. They're probably carrying extra weight, which means a lot of blood supply is going to supply fat rather than vital organs. And as a result, we see reduced testicular blood supply. And what that means is a reduction in sperm production. Interestingly, it's also associated with erectile dysfunction, which makes natural pregnancy that little bit harder as well. Too much exercise on the other hand, for men, our main concern is overheating. So the reason that testicles sit outside of the man's body is that they need to be kept slightly below body temperature to perform at their optimal level. If the man exercises a lot and his testicles get overheated, that can lead to a reduction in sperm number, but also in particular sperm quality. So the exercise that is particularly implicated for this is cycling, and I'll touch on that a little bit towards a little bit later on. For women, again, too little exercise can lead to hormonal imbalances and anovulation. So by anovulation, I mean not releasing an egg. Whilst too much exercise can also lead to pituitary dysfunction. So that's the gland in your brain that secretes hormones that stimulate your ovaries to release an egg, and that can go a little bit awry if you exercise too much, and can therefore also lead to anovulation. So we really want to know, what is the sweet spot for exercise? What is the best level of intensity? Because exercise is different. You can exercise very hard, or you can exercise very mildly. What's the best? Is there anyone who benefits more than others, and are there differences between women and men? So I'm going to sort of try and talk about the intensity of exercise initially, because this actually surprised me a little bit when I first saw it, because I didn't expect this relationship to be the case. But this is talking about vigorous exercise in women. Now, it's always, the study that talked about this is a little bit vague in what they mean as being vigorous. But if you consider very high intensity exercise as being their global definition of being vigorous, then you're probably not far off the money. And then they looked at how many hours of that type of exercise a woman did per week, and how likely she was to get pregnant. And I must admit, I thought that you'd probably get a benefit from 1 or 2 hours of vigorous exercise per week, but probably I'd have to say the results are quite similar. So when we look at studies, we talk about a thing called statistical significance, and what that is a measure of whether what we're seeing as the results of a study are due to chance alone. And the difference between no vigorous exercise and 1 to 2 hours of vigorous exercise per week, whilst it looks like there is a fall off, it wasn't what we call a statistically significant drop. So that may be due to chance. However, the difference between no vigorous exercise and 2 to 4, and indeed more than 5 hours a week, we saw a definite drop off in pregnancy rates. The study doesn't in any way explain why that's the case, but it's an observation. Interestingly, like I mentioned, this is specific to vigorous exercise, and it's not specific to all types of exercise. But there was also some sub-analysis done of this study, and looked at some specific groups to see if whether some women do benefit from vigorous exercise. And the answer was yes. So women with higher BMIs did benefit from vigorous exercise. So this little graph here shows the odds of pregnancy in women based on how much vigorous exercise they did per week. So starting at none down this end, working up with 1 to 2 hours, 3 to 4 hours, and over 5. And this one is in women with a BMI of 25. And as you can see, the more vigorous exercise women in this group did, the more likely they were to get pregnant. Interestingly, this is women who are normal weight, so women who have a BMI of less than 25. And that showed a definite fall off in pregnancy rates with all levels of vigorous exercise, which again, I must admit, I was surprised by this finding. And it's a little hard to completely explain. But I think the the answer lies in what you define as vigorous exercise. So, but I think you'd have to conclude that if you are overweight, vigorous exercise is great. And if you are normal weight, vigorous exercise may not be great and is not so great. But what about moderate exercise? What about some walking? What about some jogging? And this chart here shows you the effect on your prospects for pregnancy when you exercise moderately over the course of the week. And as you can see, women who don't do any exercise at all have a slightly lower chance of pregnancy than women who exercise for either 1 to 2 hours per week or 2 to 3 hours per week. However, if you increase your level of exercise beyond that point, you start seeing reductions. So it looks like the sweet spot for exercise in women is somewhere between 1 and 3 hours per week, which is very similar. You might remember a few slides back, Hugo gave a recommendation on, perhaps 30 minutes of walking. I think he might have said daily, but certainly a few times per week is probably hitting that sweet spot just nicely. So therefore, our recommendation is that, like I mentioned, moderate exercise is beneficial for all women. Optimal amount is about 2 hours per week. Normally when I talk to my patients, I say 30 to 40 minutes of exercise 3 to 4 times per week. And that's about where you want to be. And women with a BMI over 25 seem to benefit from harder exercise and higher intensity and more vigorous exercise. And the optimal amount for them is around about 2 hours per week. What about the boys? So the boys don't miss out either. There's really not as much data though on outcomes for men. And in particular, what we are really about is helping you have a baby. And the disappointing thing is there's really not any studies that look at the outcome of live birth in men who exercise at various levels. So we therefore have to look at other markers of fertility. And the sperm count is the easiest and the most well-studied, although I must admit not particularly well-studied. But what you can infer from this chart is that exercise seems to improve the sperm count. Now, it does look a bit weird how initially the sperm count's a little bit higher than it with less exercise and then drops and then heads back up again. But I think probably if we just assume that there's a nice steady rise with increasing exercise, I think we're probably pretty close to the money. Like I mentioned earlier, it's generally considered that overheating of the testicles is bad, and especially cycling. And there was a study, which I haven't put the graph up, that compared sperm counts for various types of sports, and it seems that the worst were triathletes. And I think that's probably because they do a lot of cycling and they had much lower sperm counts and much higher levels of abnormal sperm. And high levels of abnormal sperm make it harder for those sperm to fertilize the egg. Now, we all need motivation to do the right thing. And I think if you need to motivate the man in your life, and indeed if the man in your life is listening, this is a little startling, but erectile dysfunction is 10 times more likely in men who do not exercise compared to men who do. So I think that's a little nudge in the right direction. So my recommendations for men is that exercise is beneficial. The optimal amount is probably somewhere between 2 and 10 hours per week, and that cycling is best avoided. So smoking, I think we all know that smoking is bad, but how bad? And we know that sperm production is affected by smoking. We see reduced testicular blood flow. We see DNA damage to the sperm. We see lots of abnormal sperm on sperm checks on men who smoke. And whenever I see a sperm analysis with a man that's low and the man smokes, step one is to stop smoking. It also affects egg quality. It damages the DNA within eggs, and it affects endometrial blood flow. So we see reduced implantation, which manifests itself as negative pregnancy tests, as well as miscarriages. There are also risks throughout the pregnancy, which I won't bore you with because we all know it. But how bad is smoking? So this is a chart looking at the annual natural pregnancy rate for women who don't smoke. So we think about 85% of young, healthy, otherwise well women can get pregnant in 12 months, about 85%. But if you compare that to smokers, it drops down to about 30%. So that's a 65% annual drop in pregnancy rates for women who smoke. It's bad. What if men smoke? Well, there's some data looking at natural pregnancy rates. So as you can see, this bar just shrunk a little bit because now we're talking about monthly pregnancy rates rather than annual pregnancy rates. And in couples where the man does not smoke and the woman does not smoke, we see about a 30% chance of pregnancy per month. That must be an IVF figure, not a natural pregnancy rate figure. And if the man smokes, we see a 50% drop. So a marked decrease when the man smokes and affects his sperm. So what is recommended for smoking? Not surprisingly, we recommend that you stop. It's hard to stop smoking, but sometimes step one is to get the motivation you require. And hopefully the last few slides has been quite sobering from that point of view. And this is an effect on your health today. This is not something that's going to happen to you in 10, 20, 30 years. We're not talking about cancer. We're not talking about heart attacks. We're talking about your chance of having a baby. So stopping smoking, regardless of how much you smoke, is a definite plus. I thought I was finished. I could see Amber moving in the wings, but I'm still going to talk to you about caffeine, because this is probably, everyone knows smoking's bad for you. Caffeine, though, I get asked about it all the time, and generally my response is that a little bit of caffeine's okay. And the reason we say that is there's not a lot of data at all on caffeine and pregnancy rates, but there's even less decent data, good data, anything that you could actually learn something from. So, but what they do say is that caffeine doesn't seem to affect pregnancy rates. So your chance of getting pregnant is not really affected by caffeine intake at all. However, once you are pregnant, high levels of caffeine intake can lead to miscarriages. Interestingly, higher caffeine intake in men seems to increase miscarriages too. Now, that is obviously an effect on a man's sperm before the woman is pregnant. So probably in the lead up to pregnancy, men and women probably need to limit caffeine, and men in particular. And once the pregnancy has started, women need to limit their caffeine a little bit as well. But like I mentioned, this is poor data and mostly a guess. This, however, is the best data we've got. And it's not on natural pregnancy rates, it's on IVF pregnancy rates, and it's looking at men only. So this shows that if men drink either no coffee, 1 coffee, or 2 coffees a day, or the equivalent thereof, that there doesn't seem to be a difference at all in pregnancy rates. Once you get over that amount, though, to 2.5 to 3 coffees, we do see a drop-off. Now, this is in men, this is in IVF. I think we have to assume that that these effects are also seen in natural pregnancy, and that these effects are probably seen in women too. So what I would therefore be talking about is pre-pregnancy. 1 coffee per day for both men and women is probably fine. Once you're in the first trimester, the absolute safest thing for women is probably to drink none. But if you need 1 a day, I don't think I can sit here and tell you should stop. But if you want to be the absolute safest, you will. And after the first trimester, again, returning to 1 or 2 coffees a day is probably okay. So Amber Kennedy is definitely here now, so I'm going to hand over to her, and I'll be back for some questions at the end. Thank you.
Hello everyone, and thanks, Chris. The last lifestyle factor that we are going to discuss today is alcohol consumption. Now, we know that alcohol use can reduce your overall chance of conceiving, and this is particularly when we're talking about moderate to high levels of alcohol use. In men, heavy alcohol use is known to reduce testosterone production as well as sperm counts, and also increases the risk of impotence. It is very important also to mention that alcohol is a known teratogen. This teratogen is a substance that is known to cause birth defects. So alcohol consumption during pregnancy can significantly affect your baby. So we do know that the effect of alcohol is what we call dose dependent, meaning that the effect increases as the amount consumed increases. And this is demonstrated quite nicely in this big study of women trying to conceive and looking at the effect of the increasing numbers of standard drinks consumed per week. As you can see, up to about 10 standard drinks per week, which is equivalent of 2 per day with a couple of alcohol-free days, the effect is fairly minimal. However, with increasing use, we see a steady decline in your chance of conceiving, up to a point where at about 3 or just a little bit more than 3 standard drinks per day, or 22 per week, results in a 30% reduction in your chance of conceiving in any given month. So what is recommended? Well, most data does demonstrate that women can safely consume up to 2 standard drinks per day without affecting their chance of conceiving. However, once pregnant, there has been no safe level of alcohol intake during pregnancy established, so the current advice is no alcohol intake whilst pregnant. Okay, so now you've got all your lifestyle factors optimised. We're going to just have a bit of a chat about what to do once you're actually ready to start trying to conceive. The first thing to do is commence preconception folate. So all women trying to conceive should be on folate supplementation, and this is in order to prevent neural tube defects or spina bifida. Most folate supplementation comes in the form of folic acid, and you should be on at least 400 milligrams a day, and this should be started approximately a month before you start trying. Folate comes in different brands and multiple different formulations. You can choose to take it as part of a multivitamin, or you can take just folate on its own. The multivitamins can have a broader health benefit, such as Elevate, which contains iron, or a decent dose of iron, which can be beneficial if you tend to be on the iron deficient side. However, these different formulations can then have further side effects, such as iron causing constipation or GI upset. One good option is taking ifolic if you're just wanting to take the folate alone. This has folate plus the addition of iodine, which is required once you conceive. So once you're ready to start trying, it is all in the timing. So we know that successfully timing intercourse significantly increases your chance of success. So in this study of 100 couples who weren't particularly trying to time their intercourse, but all who did successfully end up conceiving, so we know that they're fertile, around 50% conceived after 3 months. 6 months resulted in 75% success, and just about all of them did conceive within 12 months. However, in a similar batch of couples who were fertile and attempting to have timed intercourse in order to conceive, a whopping 76% success rate was seen in the first month, and almost 100% success rate after 7 months. So we have to remember that these are fertile couples, and so this doesn't relate to everybody, but there is this obvious benefit of deliberately timing intercourse. So what does timing intercourse mean? Well, you need to identify your fertile window and time having sex in that time. We want the egg and the sperm to meet each other in the right place at the right time in order to conceive. So we know that the sperm can survive within the uterus and tubes for 3 to 5 days. On the other hand, the egg will only survive for about 24 hours after it's released. This means that the fertile window is approximately 5 days before and 1 day after ovulation. And we do see that there is a highest chance of success having intercourse 2 to 3 days before ovulation occurs. But when exactly does ovulation occur? Well, this is the standard or textbook menstrual cycle lasting 28 days. The first 14 days is called the follicular phase, named after the developing follicle, and that ends in ovulation on day 14. The subsequent 14 days we refer to as the luteal phase, and that's named after the corpus luteum, or the remnant of the ovulatory follicle. So in this classic 28-day cycle, ovulation occurs on day 14. The ovulatory window will then be day 9 to 15, and if you time intercourse on day 11, 13 and 15, then that would be ideal. However, women are not all the same, and we know that the follicular phase can be quite variable. The luteal phase does tend to be a steady 14 days. So if you have a shorter or longer cycle that's consistent, you can subtract 14 from your cycle length, and that will give you your predicted ovulation day, and you can time intercourse accordingly. However, this is where it gets a bit tricky, and many women have variable cycles from month to month. So if you have a 25-day cycle 1 month and a 32-day cycle the next month, you will need to time intercourse on day 9 to 19 second daily in order to maximise the chance that you'll cover that maximally fertile window. Now that can get a bit arduous and become a bit of a chore, particularly after several cycles. So within each cycle, there are ways that you can narrow down that prediction of ovulation. One of the ways is using cervical mucus changes and monitoring for the increase in cervical mucus volume, which is seen 5 to 6 days prior to ovulation. And then that also becomes very slippery and clear, the peak fertile mucus that we see 2 to 3 days prior to ovulation. You can also use basal body temperature monitoring, which aims to detect the about 0.5 degree rise in basal body temperature that occurs after ovulation. And then there's also urine home LH testing kits. These measure the LH level in the urine and aims to detect the LH surge. And this occurs about 2 days prior to ovulation, so it gives you that peak 2-day window. LH kits can be useful in some women. They tend to be expensive after a cumulative use over many cycles, and they also don't work very well in women with PCOS. Sometimes it can be useful to use, 2 or more of these methods in conjunction, sort of drawing from the different information that you get from each type of cycle tracking. And there are also many smartphone apps on the market that you can use to keep track of all of these different things. So now that you have timing right, what about frequency of intercourse? Well, we know from looking at semen analyses that 2 days of abstinence will lead to normal sperm parameters, but that 5 days or greater of abstinence will actually adversely affect your sperm count and semen analysis. This is one of the reasons why we actually recommend or we see a benefit to having intercourse outside of the fertile window, because it prevents the sperm being stored in the testis and deteriorating after a long period of time. But during the fertile window, what should the frequency be? Well, there is some evidence that daily intercourse may in fact be slightly better than second daily. However, that needs to be balanced against your ability to detect ovulation accurately. And if you need to cover a broad range of time, then second daily might actually be better if it makes that more achievable. Okay, so we're done with that part of the presentation. I hope you found that information really useful, and we wish you all the very best with your endeavours of trying to conceive. And we're going to take some questions now.
So we've got some questions, and we love getting the questions. And I just got one of the first questions we got was at the very beginning at 6:30, and is this webinar okay for same-sex couples? Absolutely. The information we've presented tonight doesn't matter how you're trying to have a baby. It is absolutely perfect for same-sex couples as well, whether you're trying to get pregnant by home insemination, intrauterine insemination, or IVF. All of these things are really important. So you asked your question at 6:30. I hope you stuck with us. The next question I've got is, what are the impacts of swimming on sperm, especially in cold water? And I think that's flowing from the fact that I was talking about the effect of temperature on testicles and testicular function. And what I would say is we don't have to be as worried about cool water as we do about overheating. And the reason for that is that testicles work best when they're a little bit cooler than body temperature. If a man does find himself in cold water, the testicles will be drawn up a little bit close to his body in an effort to maintain temperature. So we don't see the same effect. The dangers of cycling, for instance, is when there's heating without the ability to cool. So that's why that overheating is a bit more of a problem rather than cooling. The only thing I would say is that there was one study in particular that looked at some different sports and whether those sports were associated with difficulties conceiving. It was actually the effect on sperm counts and normal sperm levels. And that actually looked at men who played water polo, and that did show a little bit of a drop-off in sperm count and a little bit of a drop-off in normal forms. So the number of normal sperm seen on a semen analysis. But it was in men who were playing water polo for around about 10 hours per week. So they were elite water polo players. So whilst I think that study did show a difference, I don't think we can necessarily blame that on the swimming, particularly as most of their training would have been in a warm pool rather than a cold pool. And I think that was your specific question. So I might invite Hugo up to take a question now, and I'll be back soon.
Okay, Chris. So this is one that was emailed in as well earlier. This one's at lunchtime. Hopefully you didn't hang around for that entire time. So this question was, we've been trying for, we've had 2 rounds of IVF, unsuccessful, and they're trying to take a break for a couple of months. They want to go naturally. Excellent. Is there a way that they can use some of the drugs to assist? Yes, certainly. So, you know, when you see us, we're not IVF doctors, we're fertility doctors. So there's many ways to skin a cat, I suppose. And some of the medications that we use can be used at lower doses or in different ways to achieve what you're asking. So if you're wanting to just use a completely natural cycle, the first thing, as Amber had said, you need to make sure that you're ovulating every month. And the easiest way to know that you're ovulating every month is just to have a really regular cycle. And if you're regularly having a period every 28 days or even 27 days, as long as it's regular, it's almost guaranteed that you're ovulating. And if we've established that you're ovulating, then yeah, you can try naturally. Can we help you? Can we amp up or increase your chances? So yes, one of the things you suggested was the trigger, and certainly we can use a trigger in a natural cycle. So you can sort of grow the follicle yourself, and we can do an ultrasound, and when the follicle looks perfect, we can give you that same trigger injection to make you ovulate and to time sex. A better way to do that, not quite as natural, but it's still, I consider it natural, and I offer it to nearly all my patients before IVF, if it's suitable, is a simple drug called letrozole or Clomid, which I'm sure many of you are familiar with if you've been sort of on the fertility journey for a while. Medication, tablet, you take them, either one, you take them for about 5 days at the start of your cycle, and they sort of trick the brain into producing enough hormone to sort of move the production of 1, maybe 2 follicles being the sort of cysts that contain eggs, and hopefully you sort of put out 1 or 2 eggs as a result. The benefit of these was just sort of amplifying what is a natural process anyway. 2, they're really cheap. They're sort of $30 for a packet of sort of tablets that can last a couple of months. And you know, it'll make you grow an egg, and then you can trigger that, and that's probably the sort of the best ways that we can help amplify what is essentially a natural event. Chris, do you have any other questions? Do you want to come through? All right, Amber's going to come through, I think, for the next one. Cheers.
Okay, so I have an email question which has a few different parts that I'm going to address. So the question is about trying to conceive since early last year, becoming pregnant mid-year, and unfortunately having an ectopic pregnancy, which resulted in removal of one of the tubes. At the time, being told that that removal of the tubes wouldn't actually affect the fertility, and she would still be able to conceive because the fallopian tube is mobile and can collect eggs from both sides. Now, your specialist is absolutely right. In the absence of one fallopian tube, if the other fallopian tube is normal and free and mobile, it is perfectly able to pick up an egg which has been ovulated from either ovary. We tend to see about a sort of 20% to 30% reduction in the chance of conceiving each month because of that absent tube, but it's certainly possible to conceive with just one tube, as long as that one tube is normal. Unfortunately, this poster has not been successful in trying to conceive since. That ectopic pregnancy has a regular cycle, and both her and partner in their early 30s, and wondering what to do. Should they seek help, and how do they know if they are ovulating? So the most likely answer about the ovulation is that you are in fact ovulating. Having regular cycles is a very good sign, and the period comes as a result of ovulation, and they're not conceiving. So if you are having regular periods, you are most likely ovulating. And would it be time to seek help? I think certainly if it was mid last year that you last conceived and you have not conceived until now, I think it would be certainly time to seek help, and we would be definitely able to give you some answers, I think. And what are we missing? Well, I think the burning question would be to assess the function of that remaining tube. An ectopic pregnancy on one side does mean that there was potentially some pathology that resulted in that ectopic occurring, and I would want to know that that tube is in fact normal. Okay, other questions? Yep.
So, great. So the next question was by email as well, and it says, I am 43. Are there any option for over 40s women? And this is a really broad question. And the short answer is yes, of course. There are always things we can do for women of all ages. So 43 is okay. The issue at 43 is all of our efforts are going to be hampered by the fact that there may be low egg numbers and there may be lower egg quality, but there are definitely things we can do, and my advice would be to get help sooner rather than later. Next question is, can you please discuss how we can increase chances of having a safe pregnancy with women suffering from PCOS? And this is another really broad question, and I think how I would suggest we go about that is, firstly, the issue with PCOS is that you tend to be less likely to ovulate. So firstly, you've got to check if you're ovulating. If you are, that solves 99% of your problems. Then the issue becomes just following all the other health advice we have so far. If you're not ovulating, we have to then think about how can we safely and effectively help you to ovulate. And like Hugo mentioned during his presentation, you certainly are more likely to ovulate if you lose weight. You are certainly, from my part of the presentation, you're certainly more likely to ovulate if you exercise, and you can benefit from all of the other advice we followed. The likelihood, so the next question was, what is the likelihood of getting pregnant? And if you're ovulating, you're as likely to get pregnant as anyone. So even someone without PCOS, you're not less likely to conceive as long as you're ovulating. Now PCOS is associated with being overweight. If you're overweight, or indeed if you're in the obese range of the BMI scale, then that does increase the risk of miscarriages, but that's not an exclusive issue with PCOS. The likelihood of getting pregnant with our ovulation induction treatment, so we can induce ovulation in other ways beyond what I've just mentioned, so using clomiphene or letrozole, or ovulation induction with FSH injections, all options to help you get pregnant naturally. We think the pregnancy rates over the course of about 6 months is around about 30% for women with PCOS. I will now hand over to Hugo.
So the question's coming thick and fast. So there was a follow-up question about Clomid, and the question was to do with it said secretions and whether they're decreased. I think maybe talking about the endometrial lining. So one of the things that has to occur in order to get pregnant is that the lining of the inside of the uterus, which is sort of the bed for the embryo, has to thicken up. And thicker lining is good. We don't want it too thick either, because that can actually decrease your chances. And you're right, Clomid as a medication can actually make your lining thinner. Now, in some patients, that's not a big deal. In fact, last week I had a patient who had two rounds of Clomid and had quite thin lining, and in the last cycle, her lining was only 3 millimeters, which if you've not done IVF before is not particularly good. and that was on Clomid. And so we're actually going to abandon that cycle and say, look, let's move on to a different treatment. And she actually had sex, and lo and behold, is pregnant. And we found that out a couple of weeks back. So Clomid can thin your lining. Head-to-head studies between Clomid and letrozole found that this effect wasn't as pronounced with letrozole, which is why clinicians tend to use that as a treatment rather than Clomid. You also get more letrozole in a box than you do Clomid, and so it lasts for longer and is therefore cheaper. Anyway, that was the follow-up question to my previous answer. My question that I was going to take on was a patient asked, maybe two patients asked actually, how long you should come off the oral contraceptive pill before trying to get pregnant. Well, it's an interesting question. It usually is that the longer that you're on the oral contraceptive pill, the longer it's going to take for the effect sort of to wear off. But that's not necessarily so. Some patients come off the pill, and within the next month they're fertile. If you come off the pill, you should consider universally that you're going to be fertile. That's the whole point. The pill is contraceptive. Not being on the pill is not contraceptive. So if you're not planning to get pregnant straight away and you come off the pill, use condoms, barrier contraception, or some other form of contraception. By the way, withdrawal is not really contraception, but it's a really good way to get pregnant accidentally. But when you do come off the pill, what you need to realize is that the pill is actually a treatment for many gynecological conditions. So I have many patients who have been on the pill since their late teens to help control their periods. And maybe now they're in their late 20s and they've been on the pill for 10 years. And what they find is that their periods that were really regular on the pill have all of a sudden become irregular within a few months. Now, the patient, I've had a few patients say, damn that pill, it's injured me or hurt me, or it's responsible for my periods becoming irregular. The reality is that these patients probably had polycystic ovaries or another condition throughout the last 10 years. They just happen to be on the treatment, which is the pill. And what you find is when you come off the pill, because the pill is so good at bringing all your hormones back up to their normal levels, it takes a few months for them to become abnormal. So you come off the pill, hormones are normal, you may be having a period every month, every 28 days, and then it slowly, they go off kilter, and the periods also become irregular. So you need to know that, one, you should consider yourself fertile as soon as you come off the pill. Two, if you don't get pregnant straight away, well, that's not the end of the earth. That's actually very normal. Three, we need to see what happens off the pill. Do your periods return to a more normal, more regular cycle, or in fact they abnormal, and do you have something else going on? So that's my answer to the pill. Do you have another one, Emma? Excellent.
Okay, so this question relates to after sex, is it important to lay flat on your back with the legs elevated in order to maximize the chances of conceiving? Well, in fact, we get asked this question, or a version of this question, very often. Other things that people ask about, different sex positions, and also whether or not female orgasm might be beneficial. And all of these things, the theory is that they might just aid the sperm in finding the way that they need to go. In reality, we find these things are not terribly important. The sperm, once it's been deposited in the vagina, will very quickly make its way into the cervical mucus and start ascending the cervical canal. So no, you don't need to lie flat for a certain mandatory period of time after intercourse in order to improve your chances. And got Chris again. Yeah.
Like we said, lots of questions coming in tonight. Are there any tests you recommend us doing prior to making an initial appointment? And there are a number of tests that we routinely do very early on during the assessment of your fertility. And there are sort of too numerous to list. So instead, I would say that if you were interested in doing as much testing as possible prior to seeing one of the Newlife IVF fertility specialists, you could contact their rooms in advance, and certainly most of us are comfortable in providing a list of tests that are required that can then be arranged either by your GP or by the specialist rooms themselves. And then we've got a follow-up question from earlier, which is talking about whether Clomid dries up cervical mucus. And indeed, the person asking the question was indeed talking about cervical secretions. I must admit it's not something that I've heard before or been worried about in the past. And the reason that Clomid works as an ovulation agent is that it blocks, thank you, Hugo, that it blocks estrogen, the effect of estrogen on certain tissues. And so it's theoretically possible that it would reduce or change the cervical mucus to some extent. Whether that makes it better or worse, I don't think anyone knows the answer to that question. All we know is that once you've used Clomid for between 4 and 6 months, we don't really see any additional pregnancies. And as a result, we don't recommend continuing with treatment with Clomid for longer than that. Let me just have a look. Does the use of lubricant affect the chances of pregnancy? Depends. There are some types of lubricants that are better than others. Indeed, you've got to be careful because there are some lubricants that are specifically designed to damage sperm and make it harder to get pregnant. So make sure you're not using those ones, and look for ones that are specifically targeting sperm health and beneficial for sperm. How can you naturally thicken your lining if you have light periods? That's a very good question, and there are some specific treatments to thicken linings, which I'll get back to in a minute. It really depends on the context. Are you talking about a natural pregnancy? Are you talking about having an embryo transferred? Generally, when you ovulate and ovulate yourself and attempting to get pregnant naturally, the thickness of your lining is really dependent on estrogen levels and also how much lining you have. The only way you can really assess that is by doing an ultrasound. I wouldn't ever base the thickness of your lining on whether you're having heavy periods or light periods, because there is such a huge range in variation in what women experience, and it doesn't correlate well with the thickness of the lining at all. So if you are having light periods and you're worried about your lining, don't assume that one leads to the other. Instead, talk to a specialist about assessing what your lining is like. Then the issue becomes, your next question is there anything that can be done about it? The difficulty during natural cycles, the thing we use during IVF is estrogen, but it's hard to use that in the context of natural cycles because it will inhibit ovulation. One novel treatment of thickening up lining is taking Viagra, and that's certainly something we do in the context of getting a lining to be thicker during IVF cycles. So again, I would have a chat to your specialist about that so that we can answer it with all of your particular circumstances in mind. The next question, and I think it's the last question unless more come in, we'd be very happy to take more, but how do you manage endometriosis while trying to conceive? And we're very lucky because we've got an expert in the building. So I'm going to bring him on, Hugo Fernandes. Here he is.
Thanks for that intro, Chris. Can I just I'll follow up on this cervical secretions question. There's another one that's come through. So the question of cervical secretion or discharge. So the mucus in the cervix is there sort of as a filter. So not having as a filter for sperm to get through. So not having it there is not a big problem. I think the only reason that cervical mucus can be an issue in this context is whether it provides lubricant for sex. And so if the question is asked in the context of that, well, Chris has mentioned there's lots of different lubricants you can use, as long as there's one or two on the market that are okay to use whilst trying to get pregnant, and you can just use those to to create extra lubrication. And the other way to sort of, I think the question was specifically, are there any natural ways? Well, foreplay really is the only other natural way to increase lubrication, if that's the issue. But back onto the endometriosis one. Well, I actually get asked this a lot because for patients who do have endometriosis, we know that the mainstay of their treatment is hormonal. So we use the contraceptive or Mirena, which is also contraceptive, or use other hormones to try and manage their periods. Being if we can get rid of your period, then we can normally get rid of most of the symptoms of endometriosis. But unfortunately, they're all contraceptive. So how do you maintain pregnancy whilst using a contraception? Well, the answer is you can't. So unfortunately, in order to get pregnant, you're going to have to come off most of those hormones. How I manage them is to manage the symptoms. And there are several medications you can use. So the symptoms of endometriosis or associated symptoms are often pain and heavy periods. So I use a combination of two medications. So one is a non-steroidal, so things like Nurofen, Voltaren, Naprogesic, or my personal favourite Ponstan, otherwise known as mefenamic acid. And you can use those for 4 or 5 days around the time of the period. And I get my patients to start it the day before their actual symptoms start. So if you're starting to feel, or if you know in yourself that these symptoms you're getting are the pain that leads to your period, then I want you to start that medication tonight. And I want you to start 2 tablets 3 times tonight and take them non-stop for the next 4 to 5 days. And the reason that works is because one, it's an anti-inflammatory, and the symptoms that you get are actually inflammatory because a period is an inflammatory event, one. And two, they actually help decrease the volume of your period. The second medication I use is called tranexamic acid, which is otherwise known as cyclocapron, and it's purely a volume controller. It helps cause little blockages in the blood vessels so that you don't bleed as much. And that is started as soon as the period starts. And for many patients, the pain starts before the period starts. So what happens is you can use the first medication, Ponstan, for a certain number of days. In the middle, they both overlap because you have pain and heavy periods. And then you can just continue with the tranexamic acid as your period peters out. Now, the benefit of these is that I'm still giving you some pain relief. You can still use Panadol on top. If you really need, we can give you something stronger, but these often work. Number two is if you sort of get things wrong and you take these medications and you realize that you're pregnant, well, number one, if you're getting the symptoms, you're probably not pregnant because you're about to get a period. But if you happen to take them, there's no negative effect on the pregnancy. So they're safe to be on. And then we have to just juggle the two things together. So that's my main way of treating or managing endometriosis in the context of trying to get pregnant. Is there another one? Another question? So when would a woman typically ovulate on a 35 to 37 day? Are you going to do this one, Chris? You can make it.
And this may well be our lucky last unless another one comes through. So generally, and the first thing is there's a really good ovulation calculator that's on the Newlife website, and it's in the patient tools section. So take a look at that. But typically we expect you to ovulate around about 2 weeks before your expected period. So with that in mind, I would subtract 14 days from 35. And the earliest I think you would ovulate is around about day 21. But because your cycle is sometimes 37 days, you may ovulate as late as day 23. Now, there is a day or two's error either side. So I would say somewhere between day 21 and day 25 would be my answer for you. That is quite a long time to wait to ovulate. And indeed, once you do go over 35 days with a cycle, we worry about whether you are indeed ovulating at all. So I would highly recommend that you have testing to confirm ovulation to be sure that you are definitely ovulating. Is a poppy seed oil flush worthwhile? That's another controversial question. Certainly a poppy seed oil flush has been shown to increase natural pregnancy rates above and beyond of what you would usually expect when flushing your tubes with water. So just to go back a step and explain to all the people watching what a poppy seed oil flush is, it's where we inject poppy seed oil, so an oil-based fluid, through a woman's cervix and wash it all the way through her fallopian tubes and out the other end. And like I mentioned, we've seen increases in natural pregnancy rates in women who do it. It's not without its risks. So there's a risk of allergy to the poppy seed oil. It can affect your thyroid function. So it's whilst it clearly improves pregnancy rates, it's something that you need to discuss with your fertility specialist so that you understand the risks, the benefits, and whether it's the right thing for you to do. So thank you all very much for your attendance tonight. We really enjoy putting these presentations on. We particularly love going through your questions, and we've had a lot of them tonight. I think this is a record, definitely our longest webinar by far, and I'm really pleased, particularly we can see who's attending and everyone's stuck with us, so well done. They say at university that lectures that go longer than about 40 minutes, everyone drifts off, so hopefully you didn't and you've remained engaged, but the questions show that you probably did. So we've got, like I mentioned at the start, we're doing a webinar every month for the remainder of the year, and I'm going to insist that next time I present that all the presenters are roughly the same height as me, so that we don't have to keep adjusting the camera and I don't have to keep squatting. But in fact, next month I know that what we are talking about is how do you prepare for an IVF cycle? What do you need to know? And this will be a very non-medical presentation. We're not going to talk much about the medical side of things. We're going to talk about the nursing side. We're going to talk about the embryology side. We're going to talk about the psychological side. So I think anyone who is contemplating having IVF treatment in the future, that will be a really valuable webinar to attend. So the fact that you've attended tonight, we automatically update your registration for that event, so you won't need to re-register. As always, we tell you when you register for these events, if you do want to see one of the specialists who present, your first appointment will be bulk billed. Just need to let the rooms know that you have attended, and that will all be taken care of. And I can see I think the questions are done. It's just all people saying thank you. No, thank you for attending. We really do enjoy it. And we will see you next month on the second Tuesday in July. Thanks again.